In this session, we are going to discuss about acute ischemic stroke. In general, stroke is an acute neurologic injury. It may be due to brain ischemia, due to thrombosis, embolism, or systemic hypoperfusion, which accounts for 80% of stroke in general. Or it may be due to brain hemorrhage. It could be intraparenchymal hemorrhage or subarachnoid hemorrhage, which in total accounts for 20% of acute stroke. So ischemic stroke may be due to embolism, thrombosis, or other causes. From the embolism, it could be to artery embolism, cardioembolism, 30% of which is due to atrial fibrillation, or paradoxical embolism. In thrombotic, it could be large vessel thrombosis or small vessel thrombosis, which is mainly due to lipohyalurosis related to smoking, hypertension, hyperlipidemia, or diabetes mellitus. From the other cause could be arterial dissection, vasculitis, hypoperfusion, hypercoagulable state, vasospasm, endocarditis, or venous thrombosis, which causes venous infarction. Transient ischemic attack is sudden deficit due to cerebral ischemia. There is no stroke on imaging and most resolve in an hour. So risk of subsequent stroke following transient ischemic attack is thought to be around 2% by 1 week if the ABCD2 score is 4 or more. This score is extrapolated from patient characteristics and clinical presentation. So age above 60 is given 1 point, blood pressure, clinical feature, C is for clinical feature, weakness with or without speech impairment, duration of the stroke, which lasts, how much time it takes to resolve, greater than 60 minutes, 10 minutes to 59 minutes with different score, and diabetes as one score. So clinical manifestation of stroke, if it's due to embolism, it's sudden onset, and if it's due to thrombosis, may have progressively worsening course. And the clinical manifestation is specific to the vascular territory, which is affected by embolism or thrombosis or other cause. So if it is due to internal carotid artery thrombosis, there is additional ophthalmic artery manifestations with additional ipsilateral major vessels affected. When it is cerebral artery thrombosis or occlusion, the patient will have hemiplegia, which affects the leg more than the arms, and abulia, which is lack of goal-directed behavior, urinary incontinence, and the reappearance of primitive reflexes. Middle cerebral artery stroke, which leads to hemiplegia, which affects the face and the arm more than the leg, and hemianesthesia, homonymous hemianopia, aphasia if dominant hemisphere is affected, and if it is a superior division of the middle cerebral artery affected, there will be expressive aphasia. If the inferior division is affected, there will be receptive aphasia. And additionally, an apraxia, which is loss of the ability to execute skilled movements, and neglect if the non-dominant hemisphere is affected. Posterior cerebral artery, there will be macular sparing homonymous hemianopia, and alexia, inability to recognize or read written words or letters without agraphia, which is impairment or loss of a previous ability to write, and thalamic syndromes with contralateral hemisensory disturbance. Vertebral artery, there will be Wallenberg syndrome, which includes numbness of ipsilateral face and contralateral limbs, diplopia, dysarthria, dysphagia, ipsilateral horners, and hiccups. When there is basilar artery affected, there will be pupillary changes. The midbrain, there will be dilatation of the pupils. When it's a pons, there will be pinpointed pupils with small pupils, and long tract signs, which is quadriplegia and sensory loss, and cranial nerve abnormalities, and cerebellar dysfunction. Cerebral artery is affected. There will be vertigo, nausea, vomiting, diplopia, dysarthria, nystagmus, and ipsilateral limb ataxia. There are different lacunar syndromes, which includes pure hemiplegia, pure hemianesthesia, ataxia hemiparesis, dysarthria and clumsy hand, and mixed sensory motor stroke. Physical examination. The general physical exam includes murmurs, carotid and subclavian bruise, peripheral emboli, endocarditis stigmata, and in general, complete neurologic exam should be done, and NIH stroke scare should be calculated. The workups, one has to determine the electrolytes, the renal function is the glucose, the complete blood count, coagulation profile, cardiac biomarkers, toxic screening, including 12-lead ECG, stat CT to rule out hemorrhage, and CT angiography if endovascular intervention is planned. The early signs of stroke on CT scan will be hyperdense artery, loss of gray-white matter differentiation, brain edema, insular rebound. CT scan can be normal initially in ischemia and not sensitive for small and brainstem strokes. So the management of stroke includes thrombolysis. So first, let's see what are the contraindications for thrombolysis. Prior intracranial hemorrhage, non-structural cerebral vascular lesions, non-malignant intracranial neoplasm, ischemic stroke within 3 months, excluding the current stroke, suspected aortic dissection, active bleeding or bleeding diathesis, excluding menses, and significant closed head trauma or fascial trauma within 3 months. There are other lots of contraindications, but these are the major absolute contraindications. Others are relative contraindications. So thrombolysis, tissue plasminogen activator, 0.9 milligram per kg with a maximum of 90 milligram. We can give 10% of the total dose as a bolus within a minute, and the other 90% of the total dose will be infused over 1 hour. If it's given with 0 to 3 hours of symptom onset, there will be 12% absolute increase in good neurologic outcome, minimum or no disability, and 5.8 increased risk of intracranial hemorrhage, which finally leads to 4% absolute decrease in mortality due to the stroke. If it's given within 3 to 4.5 hours of symptom onset, there will be 7.4 absolute increase in good neurologic outcome and 1.8% absolute increase in intracranial hemorrhage and no mortality benefit seen. In some patients, 4.5 to 9 hours can be given, and ischemic stroke and salvageable brain tissue on imaging should be there. So it is based on the imaging as well. The other management is blood pressure management in acute ischemic stroke. If thrombolysis is planned, we have to lower it before we start the thrombolysis, and we have to maintain it for 24 hours at the level of 185 by 105 millimeter of mercury, and we can use IV labetalol or nicardipine PRN basis. If no thrombolysis planned, we allow permissive hypertension up to the level of 220 systole and the diastole up to 120. And if the patient develops symptoms with blood pressure lower than this, we have to still treat the hypertension with same medications. If the patient has also symptomatic hypotension, that means below this blood pressure, and symptomatic hypoperfusion signs, symptoms, we have to give them vasopressor and increase the blood pressure. The other treatment is aspirin. We have to initiate it within 24 to 48 hours. We can give them 162 to 325 milligram orally, and we have to avoid anticoagulation within 24 hours of thrombolysis. The other complication is cerebral edema, which usually develops within 1 to 5 days post large middle cerebral artery stroke or cerebellar stroke. The cerebral edema is increased in young individuals, so we can treat by elevating the bed, and we can give them osmotic Diuretics, we can also consult the neuropsych for hemicraniectomy, to decrease the mortality and prevent herniation. The other treatment is endovascular thrombectomy, which should be done within 6 hours of symptom onset, but we may extend up to 24 hours if imaging evidence of penumbra is there. And there are different scoring systems to do endovascular thrombectomy that we can check, and occlusion in internal carotid artery and MCA territory, respective of the other scoring systems, is also another indication for endovascular thrombectomy. Thank you for watching. Subscribe and like for more videos.